So, good evening, everyone, and welcome. We welcome you all to this first session of the Knee MRI for Orthopedic Surgeons course. With me, I have Dr. Aditya Daftari, who's a very good friend, and I look up to him for all my MRI reportings. So, I have known him for almost 12 years now, and he has been here. He has studied from US, and he is basically a clear-cut example of reverse brain drain. In fact, he taught a Dropbox to so many MRI centers where he could do remote reporting. And with this, he started his own imaging company called Innovision Imaging. And so many years back, when nobody could think of telemedicine, teleradiology, that basically he started teleradiology. That is one. Second is that he also in part-time does stand-up comedy. He's known by QuackDoc, QWAKDOC. And recently he has started his own company called Deco, where basically it will be a cloud-based image storage system, and it will be useful in the long run to us orthopedic surgeons also. With this, I hand over to Dr. Aditya Daftari to take over the session.
Thank you so much for the kind introduction, Neeraj. It's really nice to be here. I'm very excited. I think it's just something that we've always want to talk about. I think it's a great forum for us to actually, for you to get a window into the world that I live in, and for me to get a window into the world that you live in. And I think this is really, really important. So I'm not going to make this very complicated. I've already gotten enough people who have said that please don't under any circumstances bring complex physics into this. And so I won't be doing that, because one of the reasons is that I've learned to think like an orthopedic surgeon, and hence I don't understand complex physics myself. So I haven't gotten into that at all. Anyways, what we're going to try to do today is, just get back. So this is our session on knee MRI for orthopedic surgeons. We've got this broken into multiple blocks. This is a bit of a twist on something we did with Byrock a few years ago, and sort of aims to answer the common questions that orthopedic surgeons have about imaging and MR and how it helps them in their processes. I'm just putting some contact information out here in case anybody needs to reach out to us later on for anything. We'll come back to this at the end of the session as well. So what we're going to try to do today is know the appearance of structures on MRI, do a systematic review of these structures, try and figure out how we can list abnormalities, develop some sense of pattern recognition, help us to determine the diagnosis or diagnoses, stage the disease, and then give clinically relevant information. So the first part of this usually is going to be the radiology and anatomy. The second part is the pathophysiology, because once we understand the pathology of the injury or how it happens, then that helps us to determine what injury is going on. And then once we determine what the appearance of the structures are, we'll see how useful that is in order to give us the information that we need to manage a particular situation. Okay. So what we'll be doing today is we'll be talking primarily about MR imaging, sequences, and anatomy. The talk consists of 4 sections: bone marrow edema, ligaments, menisci, and common challenges. Today, we'll be focusing primarily on the MR imaging sequences and anatomy, as well as the ligaments. These are the 2 sections we'll focus on today. The others will come on upcoming sections. So the first thing that I ask people to know when they're looking at MRIs is to know what sequence you're looking at. And the importance of sequence is it tells you what structures you can see, how much you can trust the appearance of that structure to tell you what's pathologically wrong with that structure, and how you can understand biology of disease. So the one sequence that people talk about is a T1 weighted sequence. Now, when it comes to looking at internal derangements per se, the T1 weighted sequence is of little to no use for us. Okay, it's pretty good when we're looking at tumors and infection. In the old days, people would talk a lot about using T1 weighted sequences to look at the menisci and for meniscal tears. But today, with proton density images, which are the workhorse sequences that we use in MRI, we are very, very good at looking at meniscal tears. So T1 weighted sequences are the ones, if you look at all the complicated numbers that are in the corners of MRI images, you'll see something called a TR and a TE. So if you see these numbers below 1000 and below 10, then that's a T1 weighted sequence. In these sequences, fat is bright, muscle is moderate, fluid tends to be dark. And that's why we tend not to use these sequences that much, because all fluid containing structures become dark. So joint effusions are difficult to see, but it is very useful for us when we are trying to look for bone marrow edema and whether bone marrow edema is real or not. So sometimes on these fat suppressed images, we will see bright structures, but when they don't show up on the T1 weighted sequence, then we can say it's very mild edema. Whereas when they do show up as dark areas on T1 weighted sequences, we can say it's more significant edema. These show you anatomy relatively well. And they are useful because when we use contrast imaging, then they are the only sequences that we can really use to assess whether there is contrast enhancement. So T1 weighted sequence is something we do not use very often in internal derangement imaging. Very helpful when we are doing something with looking for bone edema per se. And it's also very helpful when looking at tumors, post-contrast, and infection evaluation. Now, the other sequence that we use a lot of is what we call fluid-sensitive fat-suppressed sequences. In other words, what these sequences do, they take fat and they just suppress it. So they make all the fat black. So marrow becomes flat, synovial fat becomes black, and all that stays bright is anything that contains fluid. So edema, joint effusions, some parts of articular cartilage, these will be bright. So when you look at these, normally the TR will be long, over 2000, the TE will be over 40. The fat, as I said, tends to be dark, the muscle will be dark, the fluid tends to be bright. And these don't really give you a very clear look at anatomy, but they will give you a sort of, they will give you a sense of where the anatomy is. This is not very bad that way, but they are excellent for looking at fluid and edema. Now we have two types of these sequences. One is called the T2 fat suppressed sequence, and the other is called the STIR sequence. And the importance of understanding the difference between these two is that T2 FATSAT is a real fluid sensitive sequence, whereas the STIR sequence can have some challenges with that. But the key thing is anytime you're looking at structures that are at right angles or structures that are curved, anytime you have structures that have metal in them, then what tends to happen is these patients tend to have more artifact with a T2 fat suppressed image and will have less artifact with a STIR image. So STIR is particularly good for those situations. Okay. Now, the next type of sequence that we have is the proton density sequence. And the proton density sequence, this is the workhorse. What this does is it's the Ganga Jamuna. We take a little bit of T1, we take a little bit of T2, we put them together and we get these images that give you very good anatomy. They will show you bone edema and fluid, and you get a great look at articular cartilage and everything else. So these are the workhorse sequences that we use in our practice. Many practices will use sequences in different ways. Some people will use these same proton density images with fat suppression, and we don't use them with fat suppression because it takes less time and it gives you more clarity. So we normally take one fat suppressed image to look for fluid and edema, and all the other images are focused at looking at anatomy, cartilage, and ligament. So we just use these as our workhorse sequence more than anything else. And here is excellent for looking at anatomy, excellent for looking at cartilage, and also good for looking at fluid. Okay. All right. Now, one more sequence to remember is something called the gradient echo sequence. This is not one we use very often. It is one that you will read about in publications all the time for looking at articular cartilage. This is one, and we'll discuss this more when we actually talk about articular cartilage. This is also a sequence that is particularly useful when we are sort of trying to look at the physeal lines in kids. So if you're starting to look at physeal bars and things like that, then these are kind of good. Okay, so that is sort of the other thing that we use the gradient echo images for. So they give us a good look at cartilage and they give us a good look at the physes. They're also helpful sometimes when you have fluid and you're trying to determine if there's some solid component in that fluid. Then gradient echo images are very good because they are very susceptible to artifacts. So if there's any metal or something like that, you'll get this massive blooming artifact and you'll be able to see it very clearly. But because of that, also sometimes you can get a lot of degradation of images when there is any little bit of metal. So when we come to thinking about why we need to know the sequence, we need to know which sequence we're looking at because it tells us what structures are better seen, what pathology is better seen, what kind of lesions are better seen on that. And it also tells us what we shouldn't see on those sequences, because if we look at those structures, we will get unnecessarily confused. Okay. So now moving on from that, the first part of the talk on ligaments, I think it's important for us to understand that whenever we see ligamentous injury, we should look for, especially in the acute setting, bone marrow edema. And bone marrow edema is particularly important because it sets the tone for you trying to understand the biomechanics of what injury you're dealing with. So, for example, we all know this sort of rather classic appearance of the ACL injury. When you get a pivot shift injury, you get a lateral compartment impaction, and you can get sometimes a medial impaction injury at the inner aspect of the medial tibial plateau. And sometimes you get a vaginal bone marrow edema if the MCL goes up. So this pattern of edema, when you see lateral femoral condyle, lateral tibial plateau, and posterior medial tibial plateau, when you see those three together, very, very highly likely that you've lost your ACL. Okay, so this is good. Oftentimes you may see just this one, you may see just this one, you may see just this one. You may see them in any combination in varying degrees. So you may see it very high, very low. But this triad of bone marrow edema is quite specific for helping you to determine that, yes, there's probably some injury that's happened to the ACL. Now, similarly, if we think of the PCL, there are two injury patterns that we see with the PCL. One is the direct impact. So then you'll see this impact bruise at the anterior aspect of the tibia. And the other is the hyperextension type of injury. So like here, and you'll see these two kissing contusions in lateral tibial plateau and lateral femoral condyle towards the midline. With an MCL sprain, what you tend to see is, because of the clip injury, you'll see lateral impaction bone marrow edema in the femur, and you'll see medial avulsional bone marrow edema at the femoral attachment of the MCL. And similarly with patellofemoral, you'll see at the medial patella and the lateral femoral condyle. So I think once we start thinking about ligaments, one of the important things for you to realize is to start looking at bone marrow edema. And that's where your journey begins. The moment you're able to identify a bone marrow edema pattern and fit it into a biomechanical pathway, then that really helps you very significantly in your story towards what has happened to this patient and what may not have happened. Now, moving on from the bone marrow edema, we'll start talking about the ligaments themselves. Important things for you to know is you should know the three-plane anatomy of the ligaments. It is normal to have some signal in these ligaments. They are not always completely black. The appearances, and as MR imaging technology continues to evolve, we will start to see structures in greater and greater detail. So if you took a very old MRI scanner and you looked at the ACL, it would be completely black. But if you look at today's MR images, we can actually see the fibers of the ACL really nicely to some degree. And so that's another thing that is particularly helpful. And I'm going to show you some examples of that. There's also the concept of the imaging clinical conflict. And in this, what I say is, if you were to scan somebody very early after their injury, then there's a lot of edema. There's a lot of things that look like tissue disruption, and you may overestimate injury. When you image patients too late, these tissues may remodel. They will remain continuous, but they may be lax. And we will find us reporting as saying the posterolateral corner is normal in appearance, and you'll be saying, but there is clear pivot, that I can see. What rubbish are you talking about? So we'll sort of explain some of that. Another structure that remodels very well is the PCL. So it's not unusual for you to say that, we scan somebody, say PCL looks normal, and you say, but look, there's a big posterior sag. And we've seen these patients where the PCL just remodels and looks very normal on an MRI. But if you'd had the MRI, from maybe a few months ago, then that PCL actually looked abnormal. Okay. So let's move on to the anterior cruciate ligament. Now, before this conference, somebody had asked that, do we have to take specific oblique images for the ACL? And in today's day and age, I don't believe that is necessary. It is better that you understand the ACL's appearance on regular images than take specific sequences. They do not add anything greater in terms of your ability to diagnose an abnormality of the ACL. We have a simple rule in MRI, which is called there is no free lunch. The moment you start scanning for every individual structure, you just take more and more time on the scanner. And so it is better to learn to work with what we have, and we work actually very well with it, than to do that. So, so here sort of is the example of the ACL. Now, most of you are familiar with seeing the ACL on a sagittal image. And the reason people ask to do oblique sagittal images because the ACL does not run in a single sagittal plane. It tends to be slightly off center. and therefore you may not see it on a single image. But for the most part, we get a great look at the ACL. You can see here that the ACL towards the femoral attachment is much darker, but as we get towards the tibial attachment, there are these little striations in the ACL here. And this is just because the fibers fan out, and as they fan out, there's nothing but synovial fat that interdigitates within the tibial attachment. And you see these, I'm sorry, have I got echoing of sound? Oh, okay, no, that's good. All right, so you can see these striations in the tissue, and this is what many people tend to call ACL sprain, or people tend to call these things as being, mucoid changes. But this is sort of a normal appearance that we see, and we'll talk a little bit more about this. The important things on the sagittal plane that your ACL should be running. So along the posterior intercondylar notch is what we call Blumenstadt's line. So if you consider this line here, this is going to be Blumenstadt's line. And typically your ACL should be parallel to or slightly more vertical. It should not be more horizontal than Blumenstadt's line. So that's a particularly useful thing to look at on the sagittal images. On the coronal images also, you can see here that you can see this ACL quite nicely at the femoral attachment. And as you scroll forwards, you can see it coming down towards the tibial attachment. You also see how higher up here, the ACL has a nice sort of dark appearance. But as you get down, it's got this more striated appearance because of the fibers spreading out. This structure over here is the posterior cruciate ligament. What I find particularly invaluable in looking at the ACL is this axial image, and especially towards the femoral attachment. This is a great place to look at the ACL. Now, what many people do is they do fat suppressed images. The problem with fat suppressed images is that this entire fat around here also gets suppressed, and this ACL is also dark. So it makes it very difficult to separate it from the adjacent tissues. So which is why I find non-suppressed axial images very helpful for looking at the femoral attachment of the ACL. And here you can see a nice femoral attachment of the ACL. And I'll show you some images where we can see things really nicely. So I think the first thing about this is for you to be able to trace the ACL well in the axial, sagittal, and coronal planes. Once you're able to do this consistently well, then you're going to be a long ways ahead in your journey of evaluating the ACL as a ligament itself. Okay, so now let's just look at this sequence. Okay, you look at these images, and what do people think of the ACL? Like, to me, this ACL just looks like a ball of mush. I have no idea if this ACL is intact, not intact, or what is wrong with this. Whereas if I were to look at this next image, then here I can see this is the ACL. It's got all its striations. This is sort of a normal appearing ACL to me. And when I see this, this is the image on the left here is a T1 weighted study. And the image on the right here is a proton density study on a low field scanner. Okay. And so you can see just the difference of the sequence. So don't start looking at ligaments on the wrong sequence. You look at them on a T1 weighted sequence, you're really not going to be telling ligament. You want to look at these on proton density images to get a good sense of what the ligament looks like. Now, here are some examples of some varied appearances of the ACL. So this, as we talked about earlier, is a normal appearance. You can see some of the striations. Here you can see the striations are there towards the tibial attachment, but you can see it looks more striated and irregular towards the femoral attachment. And this is when I would start to think of somebody having an early mucoid ACL. Now, this would typically not be a symptomatic mucoid ACL. It's just early mucinous changes. When we see this, sometimes we may see associated with this small intraosseous cystic changes at the femoral attachment or the tibial attachment, and those are just normal. I don't really lose much sleep over those. If you look at this one, you can see it's a much thicker and more mucoid ACL. You can see here the fibers, the mucinous change dissecting into bone and producing this intraosseous cyst here. So this is a mucoid ACL, which would probably be more significantly abnormal. This is a full thickness ACL tear. If you see the direction of these fibers, they are like this. You see Blumenstadt's line, it's like this, and you can see that this has fallen compared to Blumenstadt's line. So this is a very clear full thickness femoral attachment anterior cruciate ligament tear. And if you look at these images here, you can see that the tibia has moved forward a little bit in relation to the femur. And you can see that the PCL is buckled like this. It's a right angle appearance. And this is because this tibia has moved forward that this PCL gets buckled. So the buckled PCL sign comes from that. Now, what are some common problems? So we talked about this ACL sprain. Now we see a lot of people calling this little bit of high signal an ACL sprain. Now this is normal. If you feel that you see these striations and you can draw them with a fine pencil, then that's normal. But if on the other hand, you find they're more blurry, more hazy, bigger, and this looks much brighter, first make sure that you're looking at the correct sequence. If you see that on the correct sequence, then you want to say that, okay, maybe there's some mucoid change. Then you've got to make the decision as to whether this is mucoid change or it's something else. And, so here's sort of one, sorry, I'm just want to try and share something on, sorry, 1 second. Let me just do this. And okay, let's see. So I'm just sharing this with you on the screen, and hopefully, yeah. So you can see this when you look at the ACL. If you see slender pencil thin high signal, then this is probably normal. And this is because the femoral attachment is smaller than the tibial attachment. Therefore, the fibers fan out and the synovium fills the spaces. Now, if the femoral attachment looks small, there is bone edema or signs of an ACL injury, then you would question if there's a single bundle injury, and I'll show you some examples of that. But on the other hand, if you have a hazy appearance, almost as if you took an old felt pen and started drawing these white lines between it, if there is a history of recent trauma and there is ACL bone marrow edema, then I would start to think of a partial tear. This is a less common situation. This is probably a most common, or you'll see a full thickness tear. This is a less common situation. And most of the time, if there's no trauma or if there's remote trauma, then it tends to be degenerative change within the ACL. So this is something that I hope will be helpful to some of you in making that decision. I know that's a question that has come up very often. So I wanted to show you that. But I want to show you in this case, here you have the typical translational bone marrow edema of somebody who's had an ACL injury. And when you look at the ACL here, the ACL fibers actually look quite good. You see that? These ACL fibers actually look quite decent. So what we want to do here is, let's see here. Sorry. So what we want to do here is we look at the axial image. Now, if you look at this axial image, what you can see is this is the posterolateral bundle here. This is the posterolateral bundle here. This is the anteromedial bundle here. And you can see the posterolateral bundle is dark and intact. The anteromedial bundle has got very low signal here. And compare this to a normal ACL where you can see both bundles very dark. So this is how you would tell a single bundle partial ACL tear. So the bone marrow edema, along with it at the femoral attachment, seeing that that ACL femoral attachment is smaller than it usually should be. Moving on to a postoperative ACL, you can see here there's a normal early postoperative ACL. Here sort of delayed postoperative ACL is more attenuated. Here's mild intersubstance degeneration within the ACL. Here's moderate degeneration. And then here you can see an example of a cyclops lesion or a nodule formation. And these nodules, obviously, depending on the size, will be symptomatic to varying degrees in different people. Another thing we'll see with postoperative ACLs is whether they are too vertical visibly in the sagittal plane and in the coronal plane, which renders them unstable because the knee then swivels on each other. Or you can these situations where it's too horizontal in the sagittal and in the coronal plane, in which case it's more predisposed to impingement and can tear. Now, that being said, we've had many patients who've had bad tunnel positions, but are doing fine for many, many years. So I just will make a mention that the tunnel position is not necessarily where it should be, but overall that the ligament appears intact. Here are examples of, here you can see the ACL. You can see there's a big infection at the femoral attachment. Here there's infection at the tibial endobutton site or at the tibial button side here and here. Here you can see that there is a bioscrew here, and then you can see that there is the tunnel here. And both of these tunnels have got some edema in them, and there's a little bit of synovitis. So this could be a low-grade infection in progress. So when it comes to the ACL, make sure you see the ligament in 3 planes. You want to look at the PD without fat suppressed images, which is the best thing that I find to look at it. You will have your own local radiologist who will have different views, but ideally it's the comfort of the person who is reading the scan. So, it's the same way I try to explain this to orthopedic surgeons. There's one orthopedic surgeon who likes to test the labrum by using 3 tests. Another one will use 2 other tests. A third one will use a variation of those. So ultimately, you have to leave that to decision to the person who is interpreting the scan in terms of what planes they prefer and what sequences they prefer to use. In our practice, we find proton density without fat suppression is the best to look at ligamentous structures. The next thing is in terms of the normal striated signal at the tibial attachment. Remember, we see this very often. So everything that has got bright signal is not a partial tear and a grade 1 and a grade 2 ACL. We talked a little bit about partial and complete tears, so single bundle and full thickness tears. And when it comes to the post-operative ACL, we want to talk about the graft quality, the orientation of the graft, and the presence or absence of infection. And if it is so, then at which ends is it and how much of the ligament, etc., is involved. Moving from there to the PCL, here is a normal sort of buckled PCL that you see in somebody with an ACL tear. This little nubbin of tissue anteriorly here is the ligament of Humphrey, and there's one posteriorly, which is the ligament of Risberg. Now, this is another example. We can see a little bit of high signal within the PCL, and this is the mid-substance, low-grade PCL sprain. Whereas here you can see there's more discrete full-thickness disruption of the PCL, which is going to give you a mid-substance, full-thickness tear of the PCL. Other things that we can see with the PCL, you can see proximal peel-back lesions. We oftentimes see bony avulsions. Now, these could be acute, where you can see bone marrow edema, or sometimes these can be chronic and easily missed. So what I find with MR and with us in general is that PCL injuries are missed clinically in terms of how they present to people. And therefore, on MR, we are sometimes not always attuned to looking for them, and we may miss them easily, especially when they are chronic and the ligament looks good, and this bone may have healed in a slightly better way than this one has healed here. So that's sort of something that is particularly important to remember. So the PCL injuries are clinically more innocuous. They're easy to miss for orthopedic surgeons when somebody walks in, if somebody is not particularly attuned towards looking at these. They can be partial or complete. They can be proximal, mid, and distal, and they remodel well on MRI. So anytime you have a patient who you say, patient had an injury 6 months ago, I'm pretty sure there's PCL laxity, and you, the idiot radiologist, keep saying the PCL looks normal, realize that for us, the tissue may have remodeled well, and it's very difficult for us to tell that the PCL is torn or abnormal in those cases. And for you to demonstrate that there's laxity, then you're best off probably doing a posterior stress, tibial stress radiograph compared to the opposite, showing you that the tibia is actually translating posteriorly. Okay, now here are another ligament we look at, which is the MCL. Now here you can see this is the normal medial collateral ligament. Here is somebody where you can see the femoral attachment looks quite good, but you can see there's stripping and something coming off towards the tibial attachment. Here is a low-grade femoral attachment injury. And based on how much greater disruption this fiber shows or how much graying and thickness, we would go from low to intermediate grade. Here is obviously clearly a full thickness medial collateral ligament injury from the tibial femoral attachment. And then here's one of those cases where there's a tear at the tibial attachment and parts of the fibers are buckled in. And I suppose this is one of those situations where you might want to intervene surgically, because this will be very difficult to heal because that buckled ligament is sort of sitting within the space. Moving on from the PCL and the MCL to the posterolateral corner. Posterolateral corner injuries can be very obvious like this, where you can see the popliteus tendon and the fibular-collateral ligament have avulsed off. We can see here that you have some of these, you can have the equivalents of a posterolateral corner injury, especially in these activa injuries, where we have fibular neck fractures, posterolateral capsular injury, ramp lesions along the posterior horn of the lateral meniscus, and we can have some of these areas where the posterolateral capsule ruptures. The problem with posterolateral corner injuries is unless there's bony avulsion, oftentimes these injuries remodel well. So again, if you start to look at these patients 2, 3, and 4 months out of the injury, it's often normal for us to see these structures looking intact, but actually the patient does present with laxity. The ALL is obviously a little controversial area, but you can see it as this slender, sort of thin ligament. Here you can see a Sigon fracture with like bony avulsion here. Here you can see another example of the ALL right here. And here you can see the tibial attachment and the narrow sort of femoral attachment going up here. So when it comes to the ligaments, what I want to summarize is for all of you is to become familiar with the three-plane anatomy. It's normal, especially for the ACL, to have some signal. The PCL tends not to, but sometimes you see the double bundle appearance of the PCL. There is an imaging clinical conflict, and that comes up because some structures remodel well. So when you look at these patients later on, the structures look complete, but there may be residual laxity. And on the other hand, when you look at them early on, then you may overestimate an injury. Okay, and this is particularly true for the PCL and the posterolateral corner. So with that, I'll just stop, in terms of giving you a sense of what I've tried to do is give you some idea of what structures look like, where they are. And I thought maybe it's better for us to open this up to questions, which would help us to direct this talk in a little bit better way. Okay, so let's just start by looking at some of the questions. Let me get this here. Yeah. All right. So now, okay, so let's start with some of the questions. The first question is, what is the best time to do an MRI? Do it early and later. So the first thing is that oftentimes we don't have control about when the MR is done. But if you were to think about it, I think 48 to 72 hours post-injury is a decent time to do an MRI. Especially if you're trying to sort of determine what's going on, not over and underestimate. If you find things that are particularly abnormal in that, so if you find an MCL sprain, you find an ACL that looks like an intermediate grade injury, then it may be a good thing in these situations. So typically what ends up happening is you look at an MR and you say, okay, does this patient need to go for immediate surgery, or does this patient need to undergo some element of a period of rehab/rest before you take them to surgery? So if you look at the MR, the early MR, and you say, look, this patient needs to rest, rehab, and then we'll take them for surgery, then what I would suggest is, if you find everything looking like, okay, I know exactly there's an ACL tear, there's nothing else going on, and leave it at that, then I would say just leave it at that, and then you don't need to scan them again when you're going to actually operate. But on the other hand, if you know that there are some things, you see a PLC, you see a few other things, you see a bony avulsion, and you want to see if it's healed back, then you would repeat the scan before you would do surgery again. So that's, I hope that helps. 48 to 7, short answer, 48 to 72 is good for determining most stuff. Delayed imaging, only if somebody comes back later and something's not fitting in clinically. Lower Tesla MRI machines working in the periphery, I have to say that in general, for 99.99% of things, a 1.5 Tesla scanner with well-done images is just as good as a 3T scanner on the MR. You just have to make sure that people are doing good images or good quality images. And, I'm happy to have people reach out to us and we can help them out with getting better quality images. So that would be good. So TR and TE on an image, if you look, there's a bunch of numbers that will be written on the corner of the images. Usually this will be on the first image of the study. Oftentimes the imaging center will just put a sticker on the study saying it's a T1 study or T2 study. But if you look at the small numbers, you'll actually see a number that says TR and TE. That will help you to determine whether it's T1 or T2 weighted. Now, exact time for MRI is anytime. I'm happy to read them all the time. But yeah, like I said, 48 to 72 hours would be there. Please share soft copy of Made Easy Knee MRI. What does that mean? I don't know what you mean. Yeah, so T1 and proton density images do not look similar they don't look similar. They look very different on images. And the best thing for you to look at, find some place on the scan where you see fluid on the fat suppressed image, and look at that same place on the T1 and that same place on the proton density image. The fluid area will be dark on T1 and it will be bright on the proton density image. So they look quite different. Sequence that is best for quality of ligament, I find the proton density images to be the best. Non-fat suppressed proton density images, I find the best. The double PCL and double ACL sign on MRI, I think these are things we'll discuss more with meniscal structures. So I think that's there. which sequence the anteromedial and posterolateral bundle are best seen. And I think I showed that to you on the axial MRI images. Non-fat suppressed axial MRI images are probably the best place to see the AM and PL bundle. In ACL conservative cases, I would say you would want to repeat an MR. Typically in our practice, we end up repeating them at around 6 weeks post-injury, and we expect to see some remodeling. At that time, what happens is also a clinical exam goes on to see if there is still persistent laxity and if the patient can function well. So if the clinical parameters and the imaging parameters are adding up, then they would continue to manage that patient conservatively. Can you show where is this number of TR and T? It is on the, I guess when somebody, if you can send me a film or something like that, I can probably mark it out for you. But if I were to show you, let me do this here. If I were to show you these images here on this, hopefully you can see my screen. This number here is the TE and this number here is the TR. Can you guys see this here? Hopefully you can. The basic difference in a T1 and T2 weighted image is that a T1 weighted image shows you fluid dark, whereas a T2 weighted image shows you fluid bright. Both images will show you fat bright. If there is a massive swelling, should we go for an MRI or should we wait? You can do an MRI when there's a massive swelling. That's not a big deal at all. Just remember, if there's a massive swelling, it means that it's very acute, and that whatever findings you find, you should take with a little bit of a pinch of salt, because you may overestimate the injury when you scan very early. Proton density images are available on all scanners, so don't worry about that. Whether you have a low field or a high field, that's not an issue. On the 0.5 and 0.3 Tesla scanners, sometimes they may just go for a T1 and a T2, but I've read 0.3 Tesla scanner proton density images and they're not all that bad. Now, elaborating more about the posterolateral corner injury. So I think first things here, let me just show you some things in the anatomy. So here is, if we think about the posterolateral corner, when we look at these images here, what you can see is, this is the lateral structures, okay? If you go from anterior to posterior, and you can see this is my marker, you'll see I'm scrolling, this is way anterior, so you can see I'm anterior. Let me also bring this down. Okay, now as I scroll posteriorly on this image, what you can see, this is the iliotibial band coming down to the tibial attachment. As I keep going a little further back, what you will start to see here is the fibula. Now from the fibula, the structure going up here is the conjoint tendon. If you scroll down on these images, on the axial images, okay, what you will see here, come down here. What you will see here, this is the biceps femoris tendon coming down and going all the way down to the fibular attachment. Just anterior to that, here is the fibulocollateral ligament. You can see this dark structure as it scrolls up and comes and attaches here to the femoral attachment. So here is your fibulocollateral ligament and your biceps tendon. And this structure back here, which curves on these coronal images, this dark structure. So you see this curved structure here. This is the popliteal groove. The structure that emanates from the popliteal groove here is the popliteus tendon. And you can see it tracking back all the way to the popliteus muscle here. So these are the primary structures of the posterolateral corner. The smaller structures, when you talk about popliteofibular ligament and all the rest of those structures, they're a little bit harder to see. You'll see them with time. But isolated injuries of those structures don't really explain posterolateral corner insufficiency. So the three things I look at most commonly are going to be the conjoint tendon with the fibulocollateral ligament, the popliteus tendon, and the posterolateral capsule. Okay, now let's see what else we have here. Yeah, so I showed you the axial images on that. I'll try and show you some more structures. We're looking for discontinuity of those structures on posterolateral corner. What if there is a stainless steel and titanium plate? It's no problem. We can scan them. There is nothing to stop you from scanning orthopedic implants. We do get more artifact with them. There are ways to mitigate those artifacts by using special sequences and special techniques that are available. I think that just depends on your individual MRI center being able to do that. Okay, so more images for ACL tear, tibial mid-substantive femoral attachment. So I'll show you some images in a little bit. Now, differences in pediatric ACL MRI findings to that of the adult. So the big differences in the pediatric ACL injuries compared to the adult injuries are the fact that with pediatric injuries, one tends to see more bony avulsions at the tibial attachment than sort of ligament tears in the mid substance. So we tend to look more for the bony avulsions, and in those cases, the few things that I would do is one is talk about the size of the bony avulsion, because if it's big enough, then somebody may want to put a screw back and fix it back in. If there are small bony fragments that are off also, it's fine. In our center, we notice that people use fiber wire to fix that. So that's another thing that we've seen sometimes. And I think the key thing again in a pediatric ACL is to start talking about whether the physis is fused or not and what the extent of physeal fusion is, because then you may want to do a physeal sparing reconstruction. In your image, FS means fat suppressed. Yes, that's correct. Exactly as said. If there are no more questions, what I'd like to do is maybe just go through a few cases and some images that might be helpful. I have a couple of cases that I put together just from recently. These were just some cases that I saw in the last 2 days that I thought would be interesting, and then I have some more cases also to look at. So here, for example, is a case. Let's see if I can. So here's a case where, again, we have a case here. There's the mouse. I don't know why the mouse won't show up on this. But if you look at the ACL on the sagittal images and on the axial, so 2 images on the left, what you can see is there's some high signal within the ACL, right? But when you look at the axial image, you can see that there is, I'm sorry, I just need to get this. Maybe we'll do it this way. So you can see here that this is ACL. It's got some high signal inside it. You can see that femoral attachment has got some high signal inside it. And here you can see this tibial attachment has got a little bit of high signal inside it. And this ACL looks funny over here. But this, in my opinion, now what would you guys call this? Would you call this a tear? Would you call this a partial tear? What would you call it?
It's a partial tear.
So I would not agree with that. So because the next thing I would look at, so what I would do in that case is first I would go back and look at the images to see if there is any area of bone marrow edema or anything else that explains this abnormality. And this actually is a very typical low-grade mucoid change. So I would do 2 things. Clinically, does this patient have a history of recent injury? B, is there any translational bone marrow edema that I see that would suggest that this patient has instability? If both those things are not there, then typically this is going to be just intrasubstance degenerative change within the ACL and not really an ACL tear. There's a question here that talks about measuring the size of the ACL femoral attachment and axial when diagnosing mucoid degeneration. I don't find it useful. I do not. Now here's another case. Okay, so here, for example, we have the PCL and we have these intraosseous cystic changes here in the tibia. And you can see here, this is exactly emanating from the PCL attachment. So you can have slight intrasubstance. Please show the slide again. So please be specific on which slide so I can go back. If you didn't understand something, then let me know. But here are the images. Here is that ACL. Here you can see the fibers. When you look at these fibers, you can see that they're more vertical than Blumenstadt's line. You can see that there is just intrasubstance signal hyperintensity, but no discontinuity. There's no other evidence of other injury in this case, and this is just intrasubstance mucoid change. Here's another example where you can see the PCL and you can see some intraosseous cystic changes at the tibial attachment because of intrasubstance degeneration. And then this was another case which I thought was particularly interesting to show all of you here, which is the reverse of the last case we saw. So here, when you look at this case, you look at this ACL, it's thin, it's buckled, it's sort of narrow. And when you come towards the femoral attachment, it's not that dark appearance. So this is a partially remodeled or a poorly remodeled femoral attachment of the anterior cruciate ligament. And in this patient, I would not be surprised if they had ACL insufficiency. And in this patient, I would not be surprised if we did an MRI on this patient 6 weeks ago, that we would see that typical bone marrow translational edema and all the rest of it for that. You want to see the TR and TE images. So here we go. So here in this, if we go, you look at the bottom. I'm not sure if this is going to show because of the silly thing on my screen. You can look at the bottom of the screen here. There's TR and TE right here. Okay. So ganglion cysts of the ACL and PCL, we will not deal with separately. The thing that we look at normally for ACL ganglion cysts is you just see a more sort of cystic appearance to the ACL rather than, and you see this, like I showed you here, this mucoid degenerative appearance. We normally classify these into 3 ways using what we have done in the past, which is a purely mucoid, when you see this striated appearance, which is just thicker at the bulkier ACL. When we see it striated appearance along with like a little cystic change at the towards the femoral attachment, then we'd call that, let me just show you if I can do this 1 second. Let me just see. So this is just to show you the examples of a mucoid ACL. So we have here. So there are 3 different appearances we talk about. One is this purely mucoid appearance, where you can see it's just mucinous. 2 is this appearance where you can say mucoid change along with the cystic shunt here. So it's a mixed mucinous, mixed mucoid cystic appearance. And then 3 is where you can see this purely cystic appearance right here. And actually for these patients, what we do is we do actually ultrasound guided, decompression of these. So here's actually an example of a patient that we had with mucoid ACL. You can see the limited flexion here. And then this is the same patient with the cyst over here. And then what we have over here is you can see the cyst under ultrasound right here. And you can see it in the intercondylar notch. So this is the medial femoral condyle, the lateral femoral condyle. Just gotta do this 1 second. I think there's some markings here that have come from something else. Anyway, but here's a video and you can see the needle going into that mucoid ACL cyst. So we have the needle going in there. We can put a thick needle in, and then normally we aspirate it and we fenestrate it. And we can get aspirate sometimes we don't get aspirate. And then this is the same patient immediately after the procedure. You can see the significantly improved range of motion. So this is what we oftentimes do for patients. And we've got a study out there. We published about 50 patients or more. And now we've got well over 100 patients, which we've done mucoid ACL decompressions with this. So that is one thing that we do. Let me see, what else do we have here? Questions. Okay. The last slide, I'm sorry, I don't know which last slide now. The last slide shows significant anterior translation. Look, so I find that one thing to remember is when you're talking about anterior translations on MRI, it's a little bit difficult because the patients do get padded and packaged in this thing. So, when you I would say be careful about calling translations on an MRI. Sometimes they're very obvious and you do that. What's my threshold for ultrasound guided aspirations of mucoid cysts? It's clinical. So if a patient has significant symptoms, then we would go ahead and aspirate it. If they don't have significant symptoms, we just leave them alone. I tend to use an 18 gauge needle. So I give local, I use an 18 gauge needle to fenestrate and aspirate it. And then sometimes you can use a 16 gauge needle also. And then ultimately we inject like a little bit of steroid, so maybe over 40 milligrams of triamcinolone in and around the residual ACL. We use a posterior approach, that's right, to get into the cyst. There were some more questions that I think I missed. So there's a question here on evaluating tunnel positions. I think what I do for evaluating tunnel positions, the simple way I look at it is I try and remember what the normal ACL looks like. And then I just see if it is too far lateral, too far medial, too far anterior, too far posterior. And that being said, I don't hang my hat completely on tunnel positions, because I've seen enough patients where we have abnormal tunnel positions, but patients are doing well. So they'll come to us for a scan for something altogether different, and we'll say, oh, what the hell is this? So recurrence rate after aspiration, we have actually published this data. So this is our paper where we did ultrasound guided aspiration. So we've generally had, relatively low. I think about 70% of people don't come back to us when we've done this. So we've had pretty decent outcomes for most of these people. Okay, so this is an interesting question in terms of what is the average time you will find bone marrow edema after a traumatic injury. So theoretically, bone marrow edema can stay for up to 2 years following an injury. But normally we find that there is significant reduction in bone marrow edema within 4 to 6 weeks. And then it sort of starts to taper off after that. So when you have, you can see two things. One is you can see bone marrow edema, but also sometimes you'll see a residual effect of bone marrow edema, which is you may see a little buckling of bone. But these are slightly more subtle findings that I wouldn't really want to, encourage you to look at, because you can tend to overcall or undercall them until there. So bone marrow edema can stay, but the short answer is tends to reduce significantly in 4 to 6 weeks. By 2 to 3 months, most of the times it would be gone. But we have seen them, and there is literature out there that says it can stay for 2 to 3 months, for even up to 2 years. Okay. I was going to show you some more cases. Now, I just sort of had put together some more cases here. Let me sort of come back and do some of these. So, okay. So let's look at this case here, for example. Now, here we have a case. Here we can look at this patient. And if we start to look at this MR straight off the bat, what we realize is, as we scroll through it, we see bone marrow edema sort of anteriorly here. It's a very non-specific bone marrow edema pattern. We're not really sure what it is. You can see this tibial bone marrow edema all the way here, but it's very sort of non-specific. There are obviously changes within the menisci, which I'm going to ignore at this stage, because we're going to focus on the ligaments. And you can see that there's a bucket handle tear of the lateral meniscus here. But what I sort of found interesting about this case is when you look at this case here, you can see the tibial attachment of the PCL here. As you go towards the femoral attachment and in the mid-substance, it gets very attenuated. You don't really see great tissue here. If you go towards these axial images and you come down here, somebody seems to have their mic and everything on, but hopefully it's not disturbing anybody else. But if you scroll through this and you come from the femoral attachment and you go downwards, you can see this over here is your anterior cruciate ligament. As you come down here, this is your PCL, and it just sort of disappears over here. You don't see it very well. So this is sort of a mid-substance to femoral attachment posterior cruciate ligament injury. And this is the kind of one that one might easily miss, when you see this. Here is another case that I wanted to show you. Which is a similar thing here, where again, we look at this here, we start to scroll through these images. And what you'll see here is there's not a lot of bone marrow edema. Okay, so nothing that really tells you that there's an injury. But when you start to look at this ACL, you see it's a little bit buckled here on this fat suppressed image. But that's not a great place again to look at it. When you look at the proton density images, again, it looks a little bit buckled and strange looking over here. And when you look at it over here on these axial images, as you scroll to the top and you look towards the femoral attachment here, it looks relatively okay at the femoral attachment, but as you get a little bit lower, it gets a bit thinner. And these are the ones which make you think that this patient could have had a low-grade injury. And then you start to look carefully for bone edema and other findings. And you start to see, you can see this buckling at the crista terminalis, which we see so commonly with an ACL injury. And this patient did have clinical laxity. So this is how we sort of look at some of these hard cases. We kind of have to look for some of these little subtle findings. And the problem with this is you just need to build this up with experience, because there are enough cases where we see this little buckling, but it's just normal. It's not necessarily because of the injury. So when you find 2 or 3 things adding up that help lead you towards something, those are the times where I raise the possibility. And then I ask for clinical support to say, I'm very concerned that the ACL is torn because I see a depression in the sulcus. I see the ACL not looking great. And then if one were to start to look at this a little bit here, is there a little bit of anterior tibial translation? I'm not sure. I might look at the X-rays if there are two laterals and see if one of the tibia looks more anteriorly translated than the other. And I'd use all those tools to try and help me to sort out that case. Here is another case, where we can. It's not so great. I wanted to show you something else which I thought was kind of helpful to you. So I'm going to show you knee 6, which is okay. So I wanted to show you this case for this particular reason. So if we look at these two sequences here, they are both fat suppressed sequences, right? But if you look at this one, there's all this artifact here, right? On this one on the right. And this one on the left does not have that much artifact. And anytime you see this term IRM or trim or term, then that's an inversion recovery sequence, which is a stir type of sequence. So you can see how magnetic susceptibility artifact is reduced significantly by using that sequence when you have patients with metal, as opposed to using a traditional T2 fat suppressed sequence. So that's sort of the one thing I wanted to show you here. This is also interesting because you can see the ACL graft here. You can see the anterior fibers of the graft are buckled here, forming like a little bit of a nodule. And there are some posterior fibers that appear intact. So these are the cases that get particularly challenging, because these are situations where you say, look, there are some intact fibers, there are not some intact fibers. Is this ACL torn or not? And at those cases, what I end up doing is I start looking for bone edema. So I see that typical bone edema in the posterior medial tibial plateau. And I look here and I see that typical bone marrow edema in the posterior lateral tibial plateau. And I see a little bit of bone marrow edema in the sulcus terminalis. And when I see all those three things, and I see this ACL graft that looks a little bit weird, it looks quite discontinuous in different areas. It looks like there's a little nodule forming. Here, I would say that, look, there is an ACL reconstruction. The tunnel positions are okay. The graft appears significantly attenuated in its mid-substance, and there's some translational edema. I would favor a diagnosis of this being an insufficient graft or a failure of the ACL graft. In what cases should we recall? So proton deficient, no, these are what we call proton density images. And proton density images are something that we typically do them in all cases. So any internal derangement case. So if you were to talk about things very simply, if you have a case of internal derangement, proton density, T2 fat suppressed, and inversion recovery images. If you have a patient who has got a tumor or infection, then you're going to go with T1, T2, and T2 fat suppressed images. Okay. Is there a way to look and quantify bony incorporation? Yes, there is. So we can see better bony incorporation of the graft when you start to, it's harder and harder to separate the graft, the bone peg from the adjacent graft. That's when you will see that there is bony incorporation of the graft. How far a repeat MRI at 6 weeks will be helpful to say? So when you talk about healing, I think that's an important thing to remember that, all we are looking at on MRI is we are looking at how good the quality of collagen is. As the collagen quality continues to get better, we will see these structures darker and darker. As the quality of collagen gets worse, we will see these structures less and more hazy and brighter in appearance. But to correlate that with the clinical presence of laxity or whether a structure has healed completely. So typically, if you had an original image that shows something very bright and a later image that shows that it's much less bright, then we would say it's healing well. But for it to say that, oh, it has healed completely, I would say only if once I see it completely dark. Okay, I think we've answered most of those questions. So internal. You would say PD/PDFS, T2FS. Are we looking at anything else? Or are we done? Somebody is drawing lines on my screen. It's driving me mad. but that's okay. Okay. Anything else? Everybody gone to sleep by now? Is it just the two of us now, or what are we doing? Any other questions, Neeraj? Anything else we want to go through? I'd also, it'd be great if people put some feedback on the WhatsApp chat in terms of the format, what you would have preferred, what would be different. I've tried to just go through a bunch of different things in terms of giving you what I look at normally, what I look at abnormally, questions that people ask me regularly, things that become, ways and tips and tricks to help you with those situations. Hopefully this has helped you go a long way to this. What we can do is we have about 4 or 5 sessions for this entire course. We can allow everybody to digest this stuff a little bit. And then once that's done, we can have a sort of another doubt session towards the end, or spend some time on that. But overall, I felt it's better we give everybody a short, like half an hour talk, and then we give a longer period of time for people to ask questions, because I find that that's often the case. And oftentimes on talks, we don't know how much people have understood. Anything else? Neeraj, should we call it?
Yeah, nothing else actually. Would like to see more and more cases. And at the same time, it would be great for a person like me if you show, at least initially, how a normal would look.
Let's do that. So
now,
let me do this.
Say when you are showing pathology.
Yeah.
The same
so I've
time,
tried to do that. Yeah. So I've tried to do that I've tried to do that on some of the slides. I can't do that on all the slides because at the end of the day, this thing. Can we give you some quizzes through Google Forms? So look, for more examples, what I'm going to ask you to do, if you really want to go through this, I'm going to put in our website. This is called learn.innovisionimaging.com. You can go to this site. And look, everybody's got different things, but if you go to learn.innovisionimaging.com, what we have, and the site may change a little bit, but it's our online education portal. You can go in here. We've got a basic course for knee MRI and shoulder MRI. You can sign up for that course. And what it does is it will have specific lectures on how to read MRI. It's followed up with actual cases. The knee MR section has about 20 cases, where it actually has a form that you can fill in that, you can identify each structure, say whether you think it's normal or abnormal, compare your read with the expert, see what your report is and what you think about it. So I think, if you really want to do that, I would take this.
I thought they are for radiology students. I logged into your website.
No, it's free.
Then I said, I'm not going to become a radiologist. Let me be an orthopedic surgeon myself. And correct. Therefore, probably this class is good enough for me, I thought.
Yeah. So I'm just saying there's always people. Yeah, go ahead. Sorry, sir.
Yeah. But if the eagerness and the awareness and the curiosity goes high, maybe we'll have to sign up all those courses.
Yeah, because I think the idea over here was to give you some sort of tips and tricks to do that as best we can do within the time that we have. But if you really want to study a subject, I think one needs to really go into depth. Then I think that course is probably better suited for that. So when describing pathology, describe about the sequence a bit. So in general, when we're talking about pathology, 99% of the time we'll be talking about a proton density image if it's not black, and if it's black, then it'll be a T2 fat suppressed or a inversion recovery sequence. Best apps on PC and mobile for MRI. I'm not sure what you mean specifically that. If you're talking about looking at images, then you can get paid versions of Osirix and Horos for your iOS stuff. If you're looking at I don't know what is available on Chrome. There's a very cool site actually, which is this one, which I should probably introduce you guys to. There's this thing called the Imeos DICOM viewer. So this is this Imeos free DICOM viewer, What you can do here is quite cool. You can take any zip file once you go to this site. Let me just send you the link. What you can do is you can go in here to this site, and what you can do is you can just drag any file from your database. So if you have, for example, in downloads here, and you wanted to load the images, you can just literally go here and you can just load the files, and you can load the DICOM images onto this itself, and you can see them on this viewer. So it's a pretty cool site that I find. It's quite helpful when you're just on the fly, and it's web-based. You don't have to install anything. You don't have to do anything else. Any basic materials to refer to know basics of reading MRI images. So there's a journal in radiology called Radiographics. It's a great resource to look at this. We also have a book actually that a friend of mine has written, which is called MRI for Orthopedic Surgeons. This is a book here on Amazon. This is by Jay Khanna, who's a friend of mine, and I've written parts of the book that are for the spine, but this is a good book for you to look at. This is just MRI for orthopedic surgeons, would probably go through things that would be there. So this would be a good one on, I think it's whatever, Lippincott or whatever else. Yeah, I think, Mohammed, I appreciate your thing about sending some MRI videos in WhatsApp as a quiz. I'll see what I can do about that and see if we can help with that and see if I can send a couple of videos. But honestly, I'm not a big fan of looking at MRIs on the phone, but I'll see if I can find something. And also they tend to be it's very difficult to explain a lot of things on that. But yeah, whatever. Let me see what I can do about that. What else are we looking at here? Yeah, so let me just show you the PCL bundles. Let's see. Sorry, let me see if I can get this. Let me just see if I can find the PCL one. Sorry, guys, for this. Sometimes it's difficult to differentiate. Please have at least 3. Yeah, there will be. I think the next session is only a week later. Sometimes they will differentiate normal PCL and meniscus horizontal tear. I've not really had that be much of an issue. But let me just show you this, since you asked me about here's a normal knee MRI. And what I'll just show you is a couple of things that are areas that people can run into issues with. So one is, one second. So one issue that people run into, so if we think about this, is where when you talk about, and I think Malini will talk about this when she does the meniscus session, but couple of issues we run into. When we look at the posterior horn of the medial or the lateral meniscus, we see that there are the ligaments of Risberg and Humphrey that run anteriorly and posteriorly. And the points where those two meet the meniscus, sometimes that area can be mistaken. Also, similarly, anteriorly, where the anterior horns of the medial and lateral meniscus meet, and you have the transverse intermeniscal ligament, which is this structure here, sometimes that can be mistaken for a small flap tear. When we talk about the PCL and the ACL here, so here you can see, so this is a good example. Here you can see at the femoral attachment, you can see the anterolateral and posteromedial bundles of the PCL. So here's the one going anterior, and then coming down and going laterally. And it's going laterally because this side is where the fibula is, right? So here's the fibula. So this is the lateral side. So this is the So here are your two bundles for the PCL, here and here. And you can trace them down. Now, very often, you won't see them as two separate bundles. You'll just see them together. Okay. And here, anteriorly here, again, when you look at this, this is your anteromedial and this is your posterolateral bundle of your ACL. Does that help?
Yes.
Okay. All right. Are we done then? Neeraj, anything else? Okay, guys, I think we'll call it at that. It's 9:45. Everybody should get some dinner and some sleep if you haven't got it yet. Else jump straight to whiskey and enjoy the evening. So I think the next one, we'll announce it on the WhatsApp chat, but it should be about a week from now, hopefully next Wednesday itself. We'll focus more on the menisci and that talk and issues of the meniscus. If you have questions, just put them up on the WhatsApp chat and we'll try and get to them as soon as we can. Yep.
Oops.
All right. Okay. Cheers, everybody.
Right.